welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Hello, I'm Sina Torabi.
Hi, I'm Babak Azizzadeh.
Today, we're excited to discuss our recent publication in Facial Plastic Surgery and Aesthetic Medicine titled The Bilateral Selective Neurectomy for Bilateral Synkinesis, authored by myself, Dr. Salehi, Dr. VandeWater, and of course, the senior author, Dr. Azizzadeh. For some brief background, synkinesis is a common sequelae of any facial nerve paralysis that regenerates. Typically, it's unilateral, but it can present bilaterally, and it can be a huge quality of life issue for many of our patients who are very motivated to treat this condition. So, Dr. Azizzadeh, before getting into the meat of this paper, which is at its heart a surgical guide to this novel procedure that you've pioneered, what historical treatment options have there been for bilateral synkinesis?
Sina, thank you. So historically, we've really focused in on neurotoxins and chemodenervation, as well as physiotherapy. That's been kind of the mainstay of first-line treatments that most people get, because synkinesis, as you know, is really kind of not an underactivity problem. It's an overactivity issue in the periorbital muscles and the depressor muscles, the DAO, buccinator, platysma, mentalis, and cramping also, really overcontraction of muscles, including the zygomatic and levators. So soft tissue mobilization and chemodenervation have been excellent tools. However, the underlying issues have been that we were not able to get really great smiles out of those procedures. We can get relief of neck tightness, we can get relief of the periorbital area, but smile activity improvement has not been fantastic. So enter a lot of great surgical procedures that we've developed and enhanced over the past 2 decades, including supercharging with masseteric nerve, using gracilis muscle transfer to increase activity. But augmenting power doesn't really treat the underlying issue, which is really this co-contraction and overactivity of the depressor muscles that are preventing appropriate smile mechanism. And that's why I think the bilateral synkinesis, even though it's very rare, is probably the most difficult and challenging problem to deal with for me historically, because we just didn't have great answers.
Thank you. So that's a great transition into the meat of this paper. Can you go ahead and give us a brief synopsis of what the bilateral selective neurectomy is, what it aims to do, and how you came up with it?
Yeah, so bilateral selective neurectomy basically is really geared towards reducing and targeting the nerves that activate the essentially muscles that are counteractive to the smile. The buccinator, the DAO, the mentalis, and platysma, those are probably the 4 critical muscles. And myectomy procedures, we can target maybe DAO, but we can't really target the others. Very difficult to do a myectomy of the buccinator. Platysma myectomy is good, but not adequate on itself. So the selective neurectomy can target all of those. And at the same time, we can also, if we want to do myectomies, we can do it. So the real critical issue is, well, if we do this on both sides, can the patient have significant oral incompetence, have issues related to articulation and so forth? And that was really the challenge of how do you do this bilaterally and not be able to have those challenges? And we found that you don't have challenges in this study, and there's no real difference between this and unilateral patients in terms of major oral incompetence. And basically the procedure, we do this at the same time on both sides. We make a facelift incision, we go into the deep plane approach, subsmas, subplatysmal. We identify all the major branches that are going into the buccinator, to the DAO, to the mentalis, to the platysma. We also find sometimes the nerve that goes into the zygomatic major. We never deactivate any nerves that are helping the muscle activity. We always also try to preserve minor nerves that are going into the orbicularis. But the nerves that are really going into the DAO, the nerves that are going into the platysma, as well as the nerves that are going to the mentalis and the buccinator, we will selectively, perform a neurectomy on those. Either we take a segment of it out, or if we can't take a segment, we transect it. We use hemoclips, titanium hemoclips, to prevent kind of the nerves to regrow. If we have an opportunity, we can do a platysma myectomy or a myotomy. We can oftentimes do a DAO muscle resection, but really the neurectomy is at the core of the procedure, and we repeat this on the contralateral side. Each side is slightly different because synkinesis is never the same on two sides in patients that have bilateral synkinesis, but we try to, again, preserve the muscle, the orbicularis oris, and the depressor labia inferioris, because that really helps the lower dentition show and be able to, in addition to preserving the zygomatic major, minor, levators, and the periorbital muscles.
Spectacular explanation. One of the great things about our paper is that we were able to put together a beautiful intra-op video that I would like to point the listeners to, where we kind of explain exactly what Dr. Azizzadeh just mentioned through the video. In terms of outcomes, you kind of touched this, that the complication rates are very low, if any at all. What kind of aesthetic outcomes have you experienced? And also, before you continue, we have two amazing photos in the paper itself, before and after, that I'd like to point the listeners to.
Thank you. Yeah, I mean, for the most part, you can combine these with facelift procedures, symmetrical facial repositioning, or isolate it without any tissue repositioning. So that's the nice thing about it. You have some leeway. Again, the paper did not have a large series. It was not a double-blinded study. We didn't have a cohort of individuals that we compared, with other conventional methods. So that was not the goal of this paper. The goal was really a technical description of how to do it. But the results, based on my experience on the patients that we have, has been really, really excellent. Significant improvement in quality of life, significant improvement in smile excursion, improvement in smile show, and the patients are extremely satisfied. It's not perfect. Sometimes you have remaining neural activity into the DAO and the platysma and so forth that you need to do chemodenervation on, but it's a profound impact on the overactivity compared to any other method that we have.
In terms of patient selection, do you want patients that failed certain treatment first, or are there any certain etiologies that you won't offer this treatment for?
I mean, the main aspect of patient treatment is to make sure that the patient has, I would say, true synkinesis, not a mixed facial nerve dysfunction. There are certain patients, not a significant number, that present with maybe flaccidity in the mid-face and overactivity in the lower face, which I call mixed facial palsy. Those patients don't have enough power in the zygomatic major, minor to be able to kind of get that excursion. So they don't do as well as people who have actually moderate to severe synkinesis, where the cheek muscles, the nasolabial folds are very deep. They get a lot of contraction in the platysma and the DAO. Those patients tend to do well. Maybe not perfect smiles, but they tend to, that release of those counteractive muscles really tends to improve their quality of life as well as their smile and symmetry. We have, for the most part, etiology doesn't impact as much as the end result. We typically wait at least a year from the time of injury before doing anything. I discuss all options with patients, including chemodenervation, soft tissue mobilization, neuromuscular retraining, as well as surgery. And, in my opinion, it's very, very difficult with chemodenervation or soft tissue mobilization to get the patients to have a great outcome. So it really depends on the patient's choice, but I do offer those. I do not offer to these patients like gracilis flaps, temporalis tendon transfers, procedures to upgrade their zygomatic activity. I don't believe that's the correct thing as a first line. And again, we can always do those where we haven't burned any bridges with this technique. And so as a result, etiology, except if someone has a facial nerve tumor, a hemangioma, something that's not, it's still evolving, then we'll reassess and think about what we're going to do and go through the pros and cons.
Got it. So speaking of pros and cons, what kinds of pre-op counseling do you give these patients? Let's say they're really interested in the surgery. What do you tell them before?
Yeah, the most important thing is they have to be aware that in the first few weeks to months after surgery, they will have some oral incompetence and articulation issues, such as B's and P's. I just basically say everybody experiences, even though everybody doesn't, just so that the patients do not think that that's a problem. And they all are able to then digest that if it does happen. Whether it's unilateral or bilateral selective neurectomy, I do discuss that issue because it does happen, maybe not as often, and depends on the age and depends on how, what we've done in the operating room. So that's the first and foremost. The other thing is there is no perfection. This is a major bilateral neurologic damage, neurologic injury, nerve damage. And I always try to describe that we want to get improvement. At worst, I think they do get a significant relief in the cramping, tightness, neck, and facial issues. And at best, they're going to get a beautiful smile. And that if we need to go back, we will go back and do more work, or we have other options that are at our disposal. So we never want to overpromise anything. And we want to, obviously the surgical risks are also outlined regardless of what we do. We always discuss those. But really the main thing is this kind of initial phase of potential for oral incompetence. Long term, it takes, 1 to 2 years to kind of know what we're seeing. And I do put them through intensive physiotherapy post-op starting 2 months after surgery.
Speaking of post-op, what does immediate post-op care look like?
Yeah, this is an outpatient procedure. So most people go back home, hotel room, or sometimes go to a recovery center, but it's an outpatient procedure. Typically, most people about 10 days later, they're back to their normal social work life, day-to-day activity. 3 weeks, full physical exertion. And, soft tissue healing typically takes about 6 months. Incisions take about 1 year to 2 years. And the brain, nerve, muscle network final is probably 2 years, but 1.5 to 2 years, I would say. We'll see what the final outcome is.
Well, thank you, Dr. Azizzadeh. I think this has been a wonderful educational chat. This is certainly an area of facial plastics for which innovation is always needed. Any final words before we leave the listener?
No, I want to thank you for your contribution. You did a great job in shepherding this article to FPSAM, and I want to also really commend the journal. I think they've done an amazing job really highlighting a lot of complex reconstructive procedures.
We'd like to thank the authors for their commentary and thank you for listening to our podcast. If you'd like to explore more, please feel free to check out the article in print at the Facial Plastic Surgery and Aesthetic Medicine Journal or online. We'll catch you on the next one.